Welcome to this educational activity based on a recent live Immuno-Oncology symposium featuring Dr. Nair Rizvi from Columbia University Medical Center in New York, Dr. Hamid Hamid from the Angeles Clinic and Research Institute Cedars-Sinai Medical Care Foundation in Los Angeles, California, Professor Solange Peters from Lausanne University Hospital in Lausanne, Switzerland, Professor Thomas Pols from Bart's Cancer Center, Bart's Cancer Institute and Center for Experimental Cancer Medicine in London, England, and Dr. Nadim Riaz from Memorial Sloan Kettering Cancer Center in New York.
I think it's a particularly exciting time to be discussing immuno-oncology, given the emergence of a number of different combinations, sort of a dizzying number of combinations, some of which we'll hear about at this meeting, as well as I think a real evolution of biomarker where we're really understanding more fundamental granular mechanisms of sensitivity and resistance. And so we're going to start with Tom Powles from London, who's going to speak about immuno-oncology landscape and the role of PD-L1. We're really going to talk about cancers broadly and not really one cancer type, because many of the principles around biomarkers and combinations apply pan-cancer. And now that we're getting more immersion in genetic biomarkers, Nadim Riaz is going to talk about sort of the nuts and bolts of genetics and around genetics of hypermutation, and Solange Peters will discuss how we think about them in the clinic and review some of the clinical data around it. And finally, Omid Hamid will discuss what the future may hold in terms of new targets, combinations, and potential new biomarkers that we can use. So Tom, I'm going to turn it over to you.
No, thank you very much for asking me to come. It's a real pleasure to be here. It's unusual and refreshing to be in a city with worse weather than London. So I was going to talk a little bit about, I won't be too long. I was going to talk a little bit about PD-L1, how we test it, why we test it, and what progress we're making. And I guess the place to start with this goes back a couple of years when we started measuring PD-L1. There were a number of different antibodies that were available to us. And it became apparent quite quickly that there was different expression on tumor cells and on immune cells. And also tumors had different levels of positivity, going down from 0% all the way up occasionally up as high as 50, 60, 70%. So this gave two different moving parameters, and those two parameters together give an infinite number of possibilities of how you define positive or negative. And I guess that comes to a really important principle which I'm going to start with, which is hypothesis one, is it doesn't really matter whether the tumor cells are stained or the immune cells are stained. It doesn't really matter which antibody you use. The really only important thing is what % of cells are positive. And on the right-hand side, more than 80%, they have a much higher chance of response, and then down at the 1%, a much lower chance of response. Clearly, more patients will have 1% or more, relatively few, 50, 60% or more. And you can cut your biomarker wherever you like, and you will get different results. If you have a very high biomarker cut point, you are likely to have more responses, and a very low cut point, you're likely to have fewer responses. That's a fairly simple principle. And indeed, there is some data kicking around supporting that. And so you can see from this analysis, as you increase your percentage staining, your hazard ratio decreases from 0.88 all the way down to 0.45. You can see your confidence intervals getting wider because your sample size is getting smaller. It makes it quite a dilemma in clinical trials because in these trials, the more patients you recruit, the narrower your confidence intervals. But if you want to pick a very small group of patients with very high expression, you're likely to have wider confidence intervals. So this topic is actually very important for clinical trial design. There are more complicated issues than just black and white, positive or negative. The expression of immune cells is not uniform through cancers. And you can see here from the top you have immune deserts that have very few CD8 cells. You can see at the bottom inflamed cells, very intense infiltrate. But in the middle, and this is quite complicated because it happens in about 50% of patients in bladder cancer, you can see heterogeneous expression. Indeed, we describe this as an excluded phenotype, where immune cells are finding it hard to penetrate the cancer. And one of the things that we're discovering now is actually this immune phenotype may indeed be important. So what I've said is that expression is important, the antibody may or may not be important as hypothesis one, but I've complicated it with immune phenotype. This is a very important study, Keynote-24, and essentially this looks at a very high or relatively high level, 50% or more staining. And you can see great results both for progression-free and overall survival of single-agent pembrolizumab versus chemotherapy in lung cancer. So as it stands, our hypothesis is holding up quite nicely. But things begin to go wrong quite quickly. I use lung cancer as an example, but I can show other examples as well. CheckMate 26, Nivolumab, in a very similar population, using a different antibody, albeit at a slightly different cut point. And you can see here, this isn't panning out as you would expect, and as we saw with the previous trial. And this is beginning to suggest to us that the biomarkers may be behaving differently. And indeed, we've seen Keynote-42, which explores this biomarker cut point level in more detail. And so the beginning part of this story is the simple hypothesis that all the biomarkers are behaving the same way and the cut point is the only important level is less relevant. And actually, when you look under the bonnet, you can see here 5 drugs, and each of those 5 drugs are using different antibodies. Some are using immune cells, some using tumor cells, some using both. Different cut points of positivity. And so it should come as no surprise to you that each 5 methods are behaving in very distinct ways. And I think that is the second hypothesis, that each drug actually has a unique biomarker behaving differently. And that may be one of the reasons why we're seeing discordant results in the same tumor group. It probably, in my opinion, is not that the drugs are very different from one another. I think most people believe the drugs have more similarities than differences. But it probably means that these discordant results, particularly in the biomarker-positive population, is being driven by these different antibodies, different tests, and different methods. This is a cake, essentially. Each piece of cake represents a trial in a bladder cancer, in platinum refractory disease. The drugs are color-coded, and you can see those codes from there, Nivolumab being yellow, for example, and Atezolizumab being blue. And you can see the outer part of the cake is response rates in the biomarker-positive population, and the inner part of the cake is response rate in all comers. And you can see for the vast majority of the trials, there is some form of enrichment for response. However, this is not complete, and you can see variability with the same drug using the biomarker across trials. And this is the second really important point, is when one tries to make cross-trial comparisons, particularly in biomarker subset populations, the methodology, the inclusion and exclusion criteria of the study are actually very important. Having a compulsory biomarker component, compulsory tissue, will get different results from a randomized phase 3 because of patient selection. So I would say handle this cross-trial comparison, particularly for biomarker selection outcomes, with extreme caution. I see many comparative slides, and my take-home message for that is it's hard to compare randomized phase 3 studies, let alone phase 1 and phase 2 studies, and the biomarker component is particularly risky, in my opinion. So let's move to some randomized phase 3 studies. IMvigor 211 is a bladder cancer trial. It's a randomized phase 3 study. It's a study of individuals who have failed platinum-based therapy. They get atezolizumab, a PD-L1 inhibitor, or a dealer's choice of chemotherapy. The original trial has about 1,000 patients in it, but the primary endpoint of this trial was in biomarker-positive patients. And the question we're often asked is, why did we pick a biomarker-positive cohort? And you can see from the left hand and the right hand, the phase 1 and the phase 2 data actually shows that the biomarker was associated with a higher response rate and better overall survival in both a phase 1 and a phase 2 trial. Therefore, it's logical to pursue the biomarker in the randomized phase 3 population, particularly as the response rates in the biomarker negative population at 10% and survival at 7 months seem relatively modest. The primary endpoint of this randomized phase 3 study was negative. The reason it's negative is important. It's not because the biomarker didn't work in the atezolizumab patients. It did work. The response rates was higher. The overall survival was higher. It mirrored what we saw in the phase 1 and the phase 2. The important take-home message here is the biomarker also selected for the chemotherapy winners. So this is another very important message, in that we don't know very much about chemotherapy biomarkers. In fact, we don't know that much about biomarkers for many therapies, sunitinib in renal cancer, for example. And one of the dangers of doing randomized trial without knowing about your control arm in biomarker-positive patients is you are taking inherent risk. This is the ITT population. This is 1,000 patients. And you can see here atezolizumab outperforming chemotherapy, and indeed atezolizumab in the ITT population has FDA and EMA approval based to some extent on these data. This is the next piece which complicates the story further. We're showing inconsistency with the same biomarker, with the same drug, in the same tumor type. So both pembrolizumab and atezolizumab have been tested in bladder cancer in the frontline setting. They've also been tested in bladder cancer in refractory disease. You can see here on the left side, the atezolizumab in refractory disease, the data I've just showed you, has a higher response rate in the biomarker-positive population. But in the frontline setting, that doesn't appear to be the case. And in fact, pembrolizumab is showing something opposite. The pembrolizumab biomarker is not enriching for response rate in the platinum refractory setting, and the frontline setting is associated with a higher response rate. So to summarize this slide, we have inconsistency with the same drug in the same disease in the frontline setting and in the platinum refractory setting, and it's happened in the 2 times we've tested it. It's consistent inconsistency, and that makes me extremely nervous for the future. I wanted to move on and give a couple of renal cancer slides just to emphasize this point a bit further. So this is CheckMate 25. This is a randomized phase 3 study in kidney cancer. These patients have failed sunitinib, and they get everolimus or nivolumab, a PD-1 inhibitor. The biomarker here is purely prognostic. It is not predictive. And indeed, this drug has a broad label in this disease. You then move the same disease in kidney cancer, and this time in the frontline setting, not in the sunitinib refractory setting, sunitinib versus ipi/nivo. And you can see here now the biomarker is behaving in a predictive, not a prognostic setting. Two really important messages here. I've said it before, but we don't know about the biomarker in sunitinib. We don't know enough about the importance of PD-L1, the predictive and prognostic value, and therefore, because everolimus and sunitinib are not the same, it's very hard to say that the results of this is not because the control arm is different. But the second point I'd like to make is the biomarker appears to be behaving differently in the front-line and the second-line setting. And therefore, everything I said at the beginning of this talk about the inconsistencies we were seeing in the second-line setting may actually not turn out to be true when all these front-line trials read out in the not-too-distant future. And it's possible that actually the tissue that we've taken in these trials, which is historical, archived, paraffin-embedded tissue, in the second and third-line setting may actually not be representative. In the frontline setting, the majority of patients won't have had treatment of any description prior to going on the trial and prior to getting the therapy, and it may actually turn out that this tissue turns out to be more accurate. And the first chapter of this story, which I've described, which is mainly based around confusion, changes and becomes more accurate as the tissue becomes more representative. I'm going to talk very briefly about combinations. We don't know very much about combinations as it stands outside of melanoma. One of the things that's apparent to me is melanoma appears to be on its own in many different ways. It's particularly immune sensitive, it has a higher tumor mutational burden, it has an inflamed tumor type, and the results in melanoma appear different from the tumors that I treat, for example. Nevertheless, this is the classic study of ipi versus nivo versus ipi/nivo, and you can see from here, in the ITT population, not huge differences between nivolumab and ipi/nivo. Nevertheless, when you do subset type analysis, and you look at the biomarker positive and the biomarker negative groups, you can begin to convince yourself that actually the combination appears to be working better in the biomarker negative patients. Melanoma is a very important disease, but it's not the commonest cancer that we treat. And actually, if we're going to use immune combinations successfully, we probably will need to do that in some of the common solid tumors as well, lung cancer being an example of that. This is the ipi/nivo phase 2 data. The picture on the right refers to a randomized phase 3 study looking at durvalumab. The issue at the moment is the combinations do not seem to be performing as well outside of melanoma as we would have liked, and there is uncertainty, and the biomarker piece certainly is yet to be proven in this setting. It is likely, in my opinion, if there was spectacular biomarker results, for example, in the durvalumab arm, that trial would have been positive. If we're going to cure a lot of patients with single-agent immune therapy, it's unlikely we're going to do that in the metastatic setting, in the advanced metastatic setting. It's my personal feeling the biggest difference we're going to make is going to be in the adjuvant setting, neoadjuvant setting, perioperative setting, earlier in the disease. And we're beginning to get data from melanoma that we can have positive trials here. It is extremely important that we design these trials correctly. And one of the most important questions is whether or not they should be driven by biomarker endpoints. If you go on clinicaltrials.gov, you can find about half of them are and about half of them are not. Second-generation biomarkers are really exciting. I'm actually not going to talk very much about second-generation biomarkers because there are going to be some excellent talks and people who can do it much better than me in a second. But I am going to talk a little bit about how second-generation biomarkers build on PD-L1 by IHC. So this is coming back to that bladder cancer study in Vigor 211, where we had approximately 1,000 patients. Half of them got Atezolizumab, the other half got chemotherapy. We did RNA analysis and mutational analysis. And tumor mutational burden appears to be a biomarker that is coming out consistently across different tumor types as predictive and not necessarily prognostic. You're going to hear more about tumor mutational burden in a second. But what I would say, and is important, is if you look at the right-hand side of this, we may, by platforming these biomarkers and using 2 or 3 rather than just 1, be able to select a subgroup of patients who do extremely well. You can see from that right-hand curve that the positive patients for platinum refractory bladder cancer with atezolizumab are having exceptional outcomes that was unimaginable maybe 5 or 6 years ago by selecting patients and giving them immune therapy. This, for me, is an important story for the future, not just for single-agent immune therapy, but also for immune combinations. So I'm going to summarize. I'm going to go over what I just said very briefly. I think there is a real consistency problem at the moment. This hypothesis that the more positive you are, the higher your response rate and the better you will do is fundamentally flawed. We know that because the biomarkers appear to be behaving differently depending on the methodology. We've developed 5 methodologies. It's unlikely that all 5 will stand the test of time. It's much more likely we will be using 1 or 2 in the future. Overall, we are seeing some significant results in some studies, and it's my personal feeling in the frontline setting, when the tissue becomes more representative, we may get more consistent results. Nevertheless, the results we have currently appear antibody, drug, disease, and disease setting specific. Remember that graph showing the differences between the frontline and the platinum refractory setting for atezolizumab and pembrolizumab. The combination piece has not panned out as we've seen in melanoma in other solid tumors. It doesn't appear, as things stand in the premature data we have available to us, that it's single-agent therapy for PD-L1 positives and combination of CTLA-4, PD-L1 for biomarker negatives. Nevertheless, we are in a situation where if we are going to beat frontline chemotherapy in many solid tumors, the biomarker is going to be important. We've already seen that in lung cancer. And therefore, this effort to move and build on PD-L1 is extremely important for the future. Thank you very much for your attention.
So I think we can take some time to have a discussion amongst the panel. I think the first question is how you use PD-L1 expression testing in your practice. I think that for lung cancer, it's pretty easy. I think that everyone uses PD-L1 testing. I do have questions from the panel around that, though. For Omid and melanoma. I mean, do you based on the Ipi-Nivo versus Nivo sort of discordance based on PD-L1 status, do you use PD-L1 at all to decide on combination versus single-agent IO, or do you decide based on the patient?
So the combination is some of the data that was just presented under 1%, or some of the BRAF mutant data is somewhat convincing. We need to find out more about that. But most of the time, the patients show up without without a clear indication. What we haven't talked about is the time it takes to get these biomarkers, and at times we don't have that. I do agree that you will see better responses in the PD-L1 positives, and that might be what you're seeing in the Ipi-Nivo. What I see in that type of combination is the rapid response rate, and when you need a rapid response, that's when I tend to go there, because of some of the toxicity issues. You can always scale back and give single agent, but because of the time issues, that we've seen a more rapid and deeper response, I may be more inclined to give it to those patients. But clearly, we do need to know a little bit more about the biomarkers and where it's helpful. The ultimate end game is the overall survival, and if you've seen the data that's come out, there hasn't been a significant survival advantage in adding it in. So for me, there has to be a reason to add it in.
So you give single agent then?
I think that I give clinical trial, so stay tuned for the Hamid talk. But it depends. If there is time, yes, I would give single agent. Each patient is separate, but some of these toxicities are more difficult in a worse performance status patient. So I do not broadly give combination for standard therapy for melanoma.
So you go, and based on the patient's disease burden, how rapidly they need a response. So from both the melanoma and renal schedule is IPI of Nivo of 1 and IPI of 3 for both renal and melanoma. So it's different from lung cancer, where we give the standard dose of Nivolumab of 3 mg per kg every 2 weeks, but we only give 1 milligram of IPI every 6 weeks. So we tend to see far less toxicities. I mean, Tom, do you want to comment on the how tough it is to give 1 and 3, and do you think that for renal cancer it's so clearly superior that it's a slam dunk, everyone should get 1 and 3 of Nivo and IPI?
So in renal cancer, we're giving Nivo 3, IPI 1. But you're correct in that the phase 2 data explored all 3, and the IPI 3 Nivo 1 was deemed to be too toxic at the time. The interesting issue with that is in bladder cancer, we've got a trial looking at the IPI 3 Nivo 1 dosing, which in that elderly population is seen as being difficult to give. One of the things we haven't got to the bottom of, and I think you know as much about this as anyone else, is the importance of the CTLA-4 dosing. And but the IPI 1 Nivo 3 renal cancer data, the CheckMate 214 data, is very, very impressive, with hazard ratios of 0.63 in the intermediate and porous disease and 0.68 in the ITT population. And that is a game changer for renal cancer, because you can basically stop giving VEGF-targeted therapy. Immune therapy will replace that in the vast majority of patients, and then it's very difficult to know what to do next. The results are so good that you wouldn't want to, even in the biomarker negative population, it looks a bit better or the same. And so the biomarker is not discriminatory in that respect. One of the questions will be, in renal cancer, the next chapter is going to be the VEGF-targeted therapies in combination with immune therapy, as you were going to see in lung cancer with chemotherapy and immune therapy, and whether or not they will supersede what we've seen with Ipi-Nivo. The preliminary data, the biomarker positive data for bevacizumab and atezolizumab in Emotion 151 looks encouraging. The PFS data looks encouraging. We don't have overall survival data yet. So that story's become incredibly complicated quite quickly, and I think the biomarker may turn out to be important as time goes by.
And is there any work in melanoma or renal to look at the lung doses of IPI, where we're giving only 1 mg per kg every 6 weeks?
So there is a comparator trial in melanoma that's going to look at those two regimens. For me, I can't wait to see that data. It will help. But for melanoma, you can't overlook the role and the benefits of IPI. There was a time where we were giving 10 milligrams now in single agent, but if you look at the comparators, the 3 versus 10, the 169 trial that was presented by Paulo Acierto recently, it was blinded, and there was a significant 5-year survival benefit with the higher dose. So the discussion between 1 and 3 and 3 and 1 is okay, but for melanoma and for other tumors, I think as we're looking for other options and as we clarify where combinations really help and what happens in refractory or relapse patients, we do need to come back to understanding how that drug alone is involved in rescue.
In lung cancer, it was more a kind of a practical issue to go down, in non-small cell lung cancer, to go down to 1 milligram per kg every 6 weeks because of the toxicity observed in the O12, the phase 1 trial. With 3 milligram, it was just not feasible due to pneumonitis and fatigue and general toxicities of immunotherapy. But so we cannot answer really the rational and scientific question to know if this dose limitation would also limit the efficacy and could have been expected to be better. Interestingly, in non-small cell, we consider that problem might be that non-small cell lung cancer patients are very fragile. They are usually elderly patients as compared to yours with comorbidities. But the very interesting point is in small cell lung cancer, we have stick to the dose that you use in melanoma with the 3 milligram per kg of ipilimumab. And strangely, it was feasible, while these patients might even be considered to be more fragile. So somehow there might be here, if we think one day a way we could re-question the dose of ipilimumab in a rational manner. We have now also tremelimumab, which is dosing a little bit higher. So we could re-question that because it might be feasible to administer also in non-small cell lung cancer a higher dose. We don't have a really scientific answer to this question.
But I would also say that feasible and better may not be generalizable. Absolutely. Because the idea that it's better is great, but we still have to find something that's generalizable to the population at whole. We have huge experience and lots of support, and that's not what's in community. And I get it, IPI3 Nivo 1 has rapid onset of response, but rapid onset of toxicity, multiple synchronous and metichronous immune-related adverse events, and even with education, it's a time to become expert at it.
And the magnitude of increase of side effects should really be counterbalanced by a high improvement in efficacy, right? And that has to be proven.
Okay, well, we have a lot of questions on here as well, but I'm going to save them for the next point. I have a last question for Tom. So for bladder, should we just be giving chemo with the PD-1 therapy?
So it's a really good question. So there are at least 3 big randomized phase 3 studies that are going to read out over the next 18 months. Which will answer these questions. They all have 3 arms. 2 main thrusts of the questions are going to be answered. We currently have, for cisplatin ineligible patients, in an unselected group, we have a label for pembrolizumab and atezolizumab. So we have frontline immune therapy in bladder cancer in Europe and the US as it stands. But there's a lot of uncertainty around that. And we're not getting in control of the disease in big groups of patients. And it is my feeling that we're going to have to add to that. And so there's a trial called Danube, which adds in CTLA-4, durva-tremi, to see if you can get in better control with immune combinations. And then there's IMvigor 130 and Keynote 361 that use chemotherapy plus atezolizumab or chemotherapy plus pembrolizumab. And by giving things the chemotherapy at the beginning, you can get, I suspect, in control in the majority of patients, and I suspect those results are going to be most positive. But the really important question, coming back to what Omid said later on, is how are we going to cure these patients? Not how are we going to control them. Because my patients at the moment are coming in, looking at immune therapy, and they say want long-term durable remission. They're not looking for 3 months of extra survival. And we need to focus on that. And my fear is that we're now giving everything at the beginning, getting in control, but how many patients are we actually curing?
Great. Okay, we're going to move on to the next portion, and Nadim Riaz is coming from Sloan Kettering. He's a radiation oncologist, and his research interest is around immunogenetics, and we'll talk about how we can think about TMB. Thanks, Nadim.
It's my pleasure to be here. So I'm going to give a little bit of an introduction on tumor mutation burden and the scientific rationale for it, as well as MSI and MMR, and then Solange afterwards is going to talk a little bit more about the practicalities of using a TMB in the clinic. So as an introduction, I'm going to give a little bit of a background. We're going to first start with why we're even thinking about genetics for immunotherapy. We're then going to talk about the role of neoantigens in recognizing a cancer as foreign. We'll briefly review the evidence that tumor mutation burden is associated with response to checkpoint blockade, and I'll briefly just start the discussion of how we can move TMB into the clinic. And then I'm going to sort of touch upon topics that are going to emerge in the next year or two, which is how do we improve upon TMB as a biomarker, and there's a lot of room for improvement. And then last, we'll focus on one of the FDA-approved genetic markers for anti-PD-1 therapies, microsatellite instability. All right, so cancer is fundamentally a genetic disease, and if you look at the cells on the left side, if you think of them lining the lung or the pharynx or the colon, as we age, these cells acquire mutations, and they might be in driver genes. These dots represent specific mutations in P53, maybe CDKN2A, and once you've acquired sort of between 3 and 6 mutations, you will end up with a frank outright cancer. And that cancer continues to evolve and continues to develop additional mutations. So why are we going through this? Well, one of the fundamental objections to immunotherapy was actually the fact that people didn't understand how could the immune system recognize a cancer as foreign if a cancer originates from our own body. So these mutations, obviously, that are developing over time could be one source because these are quite unique to the cancer. And so how does this process work? Well, these mutations in the cancer wind up getting transcribed. They lead to these foreign epitopes in proteins that are then presented on the cell surface. These are not present in normal cells, and so these are quite unique to the cancer. Of course, there are other classes of antigens that are also present, and these include things like cancer testis antigens, which can be overexpressed in cancer due to epigenetic dysregulation. They include things like lineage-specific proteins like GP100 or melanin, which can be expressed. And then they, of course, include things like oncogenes, like HER2 and breast cancer, which can be over-amplified and exposed on the cell surface. However, you can notice that these other classes, not the neoantigens, are also present in normal cells. So normal epithelial breast cells will express HER2 and express the epitopes on the cell surface. Similarly, lineage-specific genes in melanoma, for example, will be expressed in melanocytes. Cancer testis antigens are a little bit more limited, however, still not as unique as mutation-based antigens. Now, that's not to say that these antigens aren't important, but it highlights how mutations in cancer really are quite unique to the cancer and can really help differentiate the tumor from self. And so I think as a proof of concept of this idea, Rob Schreiber's group at WashU sort of really demonstrated that these mutations serve a fundamental role in mediating responsive checkpoint blockade therapy in a murine model. So in a carcinogen-induced sarcoma cell line in mice in 2 different murine models, they gave both of these 2 different models a variety of different checkpoint blockade combinations, anti-CTLA-4 by itself, anti-PD-1 by itself, or the combination, and regardless of how you activated the immune system in this model system, you had complete tumor eradication. But what they did next was quite interesting in that they sequenced one of these murine model systems. They then performed computational assessments to determine which of these mutations would be presented on the cell surface of these murine tumors. And they discovered 66 epitopes that would be presented in these murine models. And then they took the T cells from these murine models and they tested each of these mutant epitopes to see which were being recognized by the murine immune system. And they identified 2 specific mutant antigens that were being recognized by the T cells after checkpoint blockade therapy. The interesting part of this study was they went one step further then. So this, up to now, suggests that these antigens were what was mediating response, but what they did next was they then provided a vaccination in these mice against these specific antigens, and that vaccination was as effective as checkpoint blockade in tumor rejection. So really, I think mechanistically and more experimentally suggesting that the target in at least this murine model were these 2 mutant epitopes. And I know Dr. Peters later is going to discuss a little bit more about how we could maybe move some of these ideas into the clinic. And so if this idea really is true, what we would expect in human tumors is that as we increase the number of mutations in a tumor, we're going to develop an elevated number of neoantigens, and we should have an increased response to therapy. And so some of the initial work demonstrating this was performed in Tim Chan's lab by Alex Snyder, initially showing that patients with melanoma who received anti-CTLA-4 therapy with elevated mutation burdens had a better overall survival than patients with low mutation burden. And then Nair showed for the first time in lung cancer that patients treated with pembrolizumab who had an elevated mutation burden had a better progression-free survival than those with low mutation burden. And of course, Luis Diaz showed this also in colon cancer for patients with mismatch repair tumors versus mismatch repair proficient tumors. And subsequently to this, multiple groups have demonstrated this. This has now been reported out in multiple clinical studies, too numerous to name, and we're going to hear a little bit more about those shortly. I think one important part of Nair's study, which sort of really demonstrated that that mutant antigen was mediating the response, was examining the peripheral blood of a particular patient. It was noted that a specific T cell that responded to a specific mutant epitope increased in frequency in the peripheral blood of this patient as the tumor was responding to anti-PD-1 therapy, as you can see here over time. Again, suggesting, like in the mouse, that this specific antigen was what was being targeted by the immune system. So I think take-home point number one is just an elevated number of mutations in a malignancy is going to increase the likelihood that a tumor will be recognized as foreign by the immune system. Okay, so how can we move this into the clinic? So I'm just going to go over very briefly just some short details. And so, of course, at performing exome sequencing, there are multiple manners of doing precision medicine studies in clinic, including the Foundation assay. Illumina has an assay now in development, and a couple of other companies also have an assay. At Sloan, we've developed our own in-house assay that uses both tumor tissue and normal tissue to call somatic mutations. And the first thing you want to assess is to make sure that the tumor mutation burden derived from a panel is going to correlate well with an exome-derived tumor mutation burden. And so this is the data from Sloan Kettering on the left, looking at about 100 cases, demonstrating pretty good correlation with a panel-based mutation burden to exome mutation burden, an R-squared of around 0.76. And on the right is data from Foundation, again, showing a relatively strong correlation based on their panel-based mutation burden compared to their exome mutation burden. And so with this panel-based data, we took all of the patients treated with immunotherapy at Sloan Kettering in a pan-cancer manner and wanted to determine if mutation load was associated with response regardless of histology. And so this is over 1,500 patients treated with anti-PD-1, anti-PD-L1, or anti-CTLA-4 therapy, and what you can see clearly is that there's a dose response. So mutation burden, as measured on our particular in-house panel, of over 25 mutations was associated with the best survival. An intermediate survival was appreciated with between 14 to 25 mutations, and of course less than 14 had the worst overall survival in this analysis. And of course, I think one question that was hinted at earlier is, well, what happens in the control group of patients that doesn't receive immunotherapy? What happens in the patients with chemotherapy with elevated mutation burden? And so we had also taken a look at that, and again, this is sort of in a pan-cancer manner. And so here you can see that patients treated with checkpoint blockade with high mutation burden, again, did better than those with low mutation burden. And patients who were treated with other agents, including chemotherapy, targeted therapies, didn't have a significant difference in their overall survival. These patients, you might note, have a slightly better prognosis. They're a little earlier stage. They had a slightly lower mutation burden, but this analysis also is similar using TCGA data, again, suggesting that mutation burden is really selective as a biomarker for immunotherapies. And of course, if you look at each individual histology, we'd seen some data earlier regarding the effect of mutation load in bladder cancer. However, across all histologies, higher mutation burden is sort of associated with improved survival. Even in the low mutation burden tumors, having a higher mutation burden in that spectrum appears to be associated with improved survival. And so this suggests that this is a sort of a pan-cancer biomarker. And Elizabeth Jaffe's group sort of demonstrated this in a slightly different manner, looking at sort of response rates in the published clinical studies and the median mutation burden in individual tumors. They sort of demonstrated that the responses were sort of linearly related to the median mutation burden in that tumor, so not using individual patient data like I just showed you. There are a couple of outliers you can notice on this graph. Merkel cell cancer, for instance, is a little bit of an outlier, but it's actually a virally driven cancer in many cases, has viral antigens that can really identify the tumors as foreign. And of course, one of our colleagues at Sloan Kettering had sort of I think very nicely also shown using the impact data and specifically looking just at non-small cell lung cancer, that there again is a dose response based on the percentile your mutation burden falls in. So tumors with the highest mutation burden or in the 90th percentile had a threefold more likelihood chance of having durable clinical benefit as opposed to those in the first quartile. And importantly, this marker is independent of PD-L1 expression, so there does not appear to be correlation between mutation burden and PD-L1 expression. The key question is what threshold to use, and many of the studies I've presented so far have all used different thresholds. I know Solange is going to go over this in much more detail in the next session. So I think take-home points number 2 and 3 are that tumor mutational load really is a pan-cancer biomarker. And that the thresholds for high and low TMB are still in flux, and we're going to hear more about how to decide on high and low next. So I want to take a step forward and think about what comes next after tumor mutational burden. And so this is work from Charles Swanton's group. You can imagine tumors obviously have very complicated clonal architectures, and so here is an example of a very complicated theoretical phylogenetic tree for a tumor. And you can imagine that mutations that are in the trunk of the tumor, if these are targeted by the immune system, we're more likely to completely eradicate the tumor as opposed to mutations in the branches, which are less likely to lead to tumor eradication. And so reanalyzing the data from Nayer's work, these patients on the left are patients who had durable clinical benefit. These patients on the right are patients who had no benefit, and on the y-axis is mutation burden. And you can note that the high mutation burden tumors here had a lot of subclonal mutations, or mutations that were isolated to the branches. And so this is strongly suggestive that having subclonal mutations is not going to facilitate response to checkpoint blockade therapies. Of course, so far we've just been talking about how to look at mutations, but the actual thing driving the response is actually the neoantigens itself. So mutation in the DNA ultimately is transcribed and translated into mutant epitope, and that epitope needs to be presented on the cell surface. But not only does it need to be presented on the cell surface, we need a T cell that's able to recognize it. So a couple of our colleagues, Marta Lutzka at the Institute for Advanced Study at Princeton and Ben Greenbaum, tried to computationally develop a first pass model to try to determine which of the mutations were more likely to serve as neoantigens. This uses a very commonly developed tool to predict binding of peptides to patient-specific HLAs. This is called NetMHC, but they also went one step further and looked at how does the binding strength of the mutant peptide differ from the wild-type peptide. So you can imagine if the mutant peptide binds much more strongly than the wild-type peptide, it's more likely to trigger a response. So they use that amplitude factor. And they also wanted to assess what's the likelihood there's a T cell that can recognize this mutant peptide. This T cell part is actually a much harder problem. And so you can think that our immune system evolved to really recognize foreign antigens or pathogens from viruses and bacteria. And so it's not going to recognize all 20 to the 9 mers equally well. And so as a first pass, what they decided to do was to suggest that mutations that are more homologous to infectious peptides are more likely to have a T cell that's going to trigger a response. And this doesn't necessarily mean that a patient was exposed to that pathogen. It more means that there's a bias in what T cells can naturally recognize, and they're really biased more towards recognizing infectious disease antigens. So combining these two features, they call these high-quality neoantigens. They incorporated the tumor clonal structure with this. and together they call these high-quality clonal neoantigens. Using this combined model, they were able to better segregate survival in both the Snyder data and the RISV data than just using tumor mutation burden alone. And then in one of the earlier tumor mutation burden data sets, where mutation load was very weakly associated with response, they were also able to show a much more significant change in survival. The graphs on the bottom illustrate that all components that I just mentioned are important in trying to predict response to therapy. So we've focused a little bit now on sort of counting tumor mutations. We focused on trying to predict which neoantigens might trigger an immune response. But one thing we haven't discussed is the genetics of the HLA locus itself. And so just to remind everyone, HLA class 1 is responsible for presenting antigens to CD8 T cells, and there are three main classes of HLA-1 genes, A, B, and C. And the HLA genes are actually some of the most polymorphic genes in the human genome. So there are three classes of these genes, and we inherit one copy from mom and one copy from dad. So each of us, for the most heterozygous as possible, should have 6 copies of these genes. And the reason they're very polymorphic is so that you can present as many peptides as possible on the cell surface. So if you only have 5 unique copies or 4 unique copies, theoretically, you're not going to be able to present as diverse a range of peptides on your cell surface as if you have all 6 copies. And so, of course, some people are maybe a little more, some people's mothers and fathers are maybe a little more related than you would have thought. And so, although most of us have 6, maybe like 75% of us, 25% of us have 5 or 4 unique copies. And so what we discovered, looking at all the exome data, if you have only 5 or 4 copies, you actually have a significantly, again, worse overall survival than if you have all 6 unique copies. This is all of the public exome data that was available when the study was performed, and this is our targeted sequencing data sort of validating that finding. Now, if this is really true, we also know that tumors are very copy number unstable, and so although you could have 6 unique genes, 3 unique ones from mom and 3 unique ones from dad, the tumor sometimes can undergo an event called a loss of heterozygosity event. And actually, all 3 of these genes are on chromosome 6. So the tumor can just sort of knock out chromosome 6, and now in this particular scenario, you only have chromosome 6 from your mom, so you only have 3 copies. And so again, we sort of see very similar findings in the exome data that if just this event occurs, patients with just this type of event have a significantly worse overall survival than patients who don't have this event. We've also found a similar result to this in our targeted sequencing data, but we're a little less confident in our ability to call this event accurately in our targeted sequencing data. So I think together these suggest that the genetics of this locus also influence immune response, and not surprisingly, you can combine these 2 features together and better stratify patient outcome. All right, so I want to just take one step away from a biomarker angle and just try and provide a little bit of additional sort of proof of concept data from a study that we had performed ourselves, which was trying to see if the neoantigens really are what is being targeted by the immune system. So I've shown you sort of very convincing data from mice that you can vaccinate against those antigens. We don't have that level of data in human, although I think we're going to hear about some of that in the next session. So I think this is sort of the first proof of concept study that these are being targeted. And in this study, we sequenced tumors pre-therapy and 1 month into treatment. And we looked at what happened to mutations during therapy. And so you can see there are some mutations here that stay at 100% in both pre-therapy and on therapy. And then there's some mutations that disappear during pre-treatment, and there's some mutations that appear on treatment. We also wanted to assess what would happen to the T cells during treatment. And so each T cell has a unique barcode that codes the TCR. It's a combination of the V, D, and J segments. And you can generate a unique barcode for this, and you can sort of determine how many T cell clones are expanding in a tumor. So what you could imagine happening is there is a specific T cell that targets a specific set of mutations or a specific part of the tumor and knocks that out. Here is another one that knocked out the red part, and here was a purple clone that knocked out the purple part. And so what we can generally think of is if the T cells are recognizing mutations, we would expect the number of T cell clones that expand during therapy to be directly proportional to the number of mutations lost during treatment. And so because I gave you that introduction, not surprising, that is what we actually found, that in patients who respond to therapy, the number of unique T cell clones that expand is directly related to the number of neoantigens that are lost on therapy, and that only happens in patients who respond. So I think that provides additional sort of proof of concept data that in humans this is sort of a strong component of the mechanism of action of these agents. So I think the take-home point here is that tumor mutation burden is going to be refined in the near future by incorporating information including the clonality of the mutations, HLA genotyping, and neoantigen prediction algorithms. All right, so in the last few minutes, I want to talk just briefly about one of the classic view of cancer genetics, which is looking at sort of driver mutations and how they can be targeted. And we know a variety of these driver mutations have different immunologic effects. I think the most clear set of driver mutations and tumor suppressor mutations that have an immunologic effect are those that have impacted mutation load. And so I'm going to focus on those, although this review published in Immunity just a few weeks ago goes over sort of the more classical oncogenes and how they may affect immunity. And so the DNA damage response actually is composed of multiple pathways, and these pathways are responsible for repairing a variety of different lesions. And of course, the one pathway that is indicated for an FDA-approved biomarker is defects in mismatch repair tumors. Of course, there are multiple other DNA damage repair pathways that are being investigated. They create each defect in each pathway creates a unique type of lesion. And I would say stay tuned. There's more to come in this space beyond mismatch repair, I think. So the mismatch repair system canonically involved a germline hereditary syndrome involving inherited mutations in MSH2, MSH6, MLH1, or PMS2. And these can lead to hypermutant tumors because during a replication of your DNA, you wind up having small errors, especially at microsatellites, which can lead to these slippage events and can lead to insertion and deletion type mutations. And so this is sort of an example of what a microsatellite looks like. A microsatellite is just sort of a long repeat. It's usually 1 to 3 nucleotides that's repeated like A here. And this is sort of the normal example. And you can see in the tumor, this microsatellite has expanded, and there are increasing insertion and deletions in this particular tumor. And so this phenotype has historically been associated with uterine cancer and colon cancer, but this work published a couple of years ago shows that it's actually prevalent at a low incidence in a wide variety of malignancies. And when it is present in those malignancies, down here you can see there's an elevated immune score in those cancers when it's present, even though it only occurs at a low incidence in those tumors. And so, of course, Luis Diaz initially showed in colon cancers that these tumors respond much more significantly to anti-PD-1 therapy compared to tumors that are proficient. Then, of course, published in the spring of last year, he expanded this analysis to pan-cancer analysis, and here you can sort of see the waterfall plot. Regardless of histology, the responses are quite high to anti-PD-1 therapy, and so the FDA has now approved mismatch repair as an FDA indication for anti-PD-1 agents. At ASCO SITC, this data was presented, which was looking at sort of the combination of Nivolumab plus Ipilimumab in this setting. And again, we saw very good response rates and good overall survival. So how can we measure this in clinic? So there are historical clinical testing strategies, including IHC staining. There are classical sequencing methods to look at 5 specific microsatellites and count the number of microsatellites that are unstable, and of course there are next generation sequencing techniques. So I'm going to skip the classic ones and just end on this last slide, which looks at next generation sequencing based techniques, because many people are being sequenced already for looking for driver mutations. The next generation sequencing-based methods may offer a convenient mechanism of finding those low incidence cases in prostate and lung cancer that might have microsatellite instability. And so using sequencing-based techniques, you can have equal sensitivity and specificity to the canonical tests. So in summary, tumor mutation burden is a pan-cancer biomarker response to checkpoint blockade therapy. We're going to hear a little bit about the thresholds for tumor mutation burden in a minute. I think the future of there's a lot of room to improve tumor mutation burden, including things like clonality, neoantigen prediction, and HLA genotype. And then, of course, in terms of mismatch repair deficiency, this is one of the actually first FDA pan-cancer biomarker approved in any setting. And the status can be determined by the classical assays such as IHC and PCR testing, but I think NGS assays will have a large role in assessing non-colon and endometrial cancers. Thanks.
Okay, thanks, Valentin. Okay, just one quick question. I think we're going to move on to the next session, just time reasons. How do you, one of the questions that we had on the list was how does MSK impact compare with Foundation? And with all these assays out there, it seems like the threshold that's being propagated for lung cancer around 227 lung data is 10 mutations per megabase by Foundation. So how would we use that with impact? And also the second part of the list of questions here is, do you think the thresholds are going to be the same across cancers, or are we going to have different thresholds? And the third part of that list is, how do indels and versus other passengers factor into this thinking?
Okay, so I think every panel, the correlation between the panel and exome sequencing for mutation burden is slightly different. And so it really depends on what genes are in the panel and the informatics pipeline that's used to analyze the panel. And so there is an effort to try and harmonize the different mutation burdens from these different panels. But right now, you can't take a cutoff developed with one panel and apply it in a very straightforward manner to another panel, because they're not going to be directly related, because they're not sequencing the entire exome. In terms of the thresholds for particular cancers, I think our initial impact data suggests that the threshold is going to be actually different for each individual cancer. However, the cases in the traditionally non-treated, or the cases in the cancers that don't have an FDA indication, the numbers are quite low. So I think our data is strongly suggestive that it's going to be per cancer, but I wouldn't say we have a final answer on that. And then the last part of your question was regarding indels, or
how do we think? How do you figure out if an indel, how many new epitopes it generates, and how clinically important is that?
Yeah, so I think I pointed out that one exception, which was Merkel cell cancer, but there are actually two other exceptions that break this tumor mutation burden paradigm, with higher mutation burden being associated with response, and that's Hodgkin's lymphoma and renal cell cancer, which is classically a low mutation burden tumor. And so in Hodgkin's lymphoma, these tumors actually have an amplification of PD-L1 to drive oncogenesis, which is why they have a high response. In renal cell cancer, although they classically aren't thought to have high mutation burden, they actually have one of the highest indel counts of all cancers. And so I think indels clearly are more immunogenic, because these frame shifts generate long strings of peptides that are foreign, but how to incorporate indel count into mutation burden isn't clear just yet.
Okay, I think we're going to keep moving forward for time reasons. Solange Peters is going to speak to us. She's from Lausanne, and we'll talk about the clinical application of TMB and MSI.
Thank you. It's a pleasure to be here. I will repeat some of the data, but try to cover in a comprehensive manner with the clinical evidence and potential practicalities for you, wherever you work or wherever you live, in terms of trying to implement this type of biomarkers. So let's first start with the first steps of defining tumor mutational burden as a biomarker, which was related to the use or correlated to whole exome sequencing analysis. And as this slide was shown before, we started from, of course, melanoma, which always is the key player in starting to develop strategies in immunotherapy, and focused quite rapidly on non-small cell lung cancers. These data have been discussed, and I will show you some more data later on. But it's important to say that in most of the cancers nowadays, you have individual data from clinical trials showing you that tumor mutation burden might be a biomarker. And this is not the case for PD-L1, as it was extremely well shown in the first discussion today. So I'd like just to tell you the difference between having consistent biomarkers enhanced here as compared to PD-L1, which was showing some discrepancies, like it was told before. So let's start with some clinical data to show you where we come from. And we are in the whole exome sequencing environment. And this is the first article from Snyder and colleague in melanoma, where you can see that, of course, per disease, the threshold will be different. And in this paper, you can see that the durable clinical benefit, meaning response, complete or partial, or long stabilization of the disease from 6 months or more, was improved when you met a threshold of 100 mutations per sample in melanoma. This is the really founder publication, but followed very rapidly by the one of Nair Rizvi, showing that with another threshold of 200 mutations per sample, still using whole exome sequencing, you can see the difference in progression-free survival. And again, most of the patients having a durable clinical benefit with high level of mutations, but also a kind of additive effect when PD-L1 expression could be there positive, but no correlation between both. We will come back to this later on. What is interesting with tumor mutation burden and beyond the PD-L1 is you can revert negative trials, which were negative based on PD-L1 selection, to positive trials. And this is the very famous CheckMate 26, which was negative, selecting patients with 5% PD-L1, which became positive from Nivolumab as compared to chemotherapy frontline when you were not looking at PD-L1 but tumor mutational burden. Again, here the threshold is high, 243 mutations per sample, bluntly defined by the highest tertile of mutation in this trial. Importantly, on the right panel, it looks like chemotherapy is better than immunotherapy in low mutational burden context. And I must stress here that these data were not strongly reproduced in other clinical settings where more an equivalence was found. We tried also to explain at the last AACR meeting how is it possible, and this is the key slide about PD-L1 and tumor mutational burden, how is it possible that these two biomarkers are completely not correlated? And the idea is quite simple. You don't need a high number of mutations to have a very immunogenic epitope. It's not a question of number. And sometimes you can have a high number of mutations, but T cells might have difficulties to traffic and to go up to their function into the tumor, to kill the tumor, which is called T cell exclusion from the tumor. And this can happen and explain this phenomenon. So you are not seeing at the same level, at the same time of the immune response, and they may completely be divergent. So very importantly, we continue with a set of data I described before, and we are speaking about toxicities. Nivolumab in small cell lung cancer, you know it's probably one of the worst diseases we treat. Again, with a threshold of mutation burden, which is kind of similar to non-small cell lung cancer, 247. Just look at the right panel. You use Nivo in high mutation burden in late line, and suddenly your 1 year overall survival becomes extremely interesting, never seen before in small cell. So here again, we move quite a lot the field. And again, whole exome sequencing in pretreated urothelial cancer with a completely different number of mutations. You can see that here the number becomes lower again. You can see here that overall response rate is strikingly dependent also on mutation burden, high as compared to medium or low rate of mutation burden, showing you that in that disease too, whole exome sequencing has paved the way. And we have been discussing mismatch repair, microsatellite instability, how much it might impact overall survival curve. And you can still see here that the phenotype of this mismatch repair is the mutational burden. And look at the number of mutations found in mismatch repair in instability as compared to non-instability is 1,782 mutations versus 73. So here you are really in two very different paradigms explaining user survival curve. Last but not least, it's an interesting whole exome sequencing analysis of various tumor types in two phase 2 trials, Keynote 12 and Keynote 28, many different tumors. And you can see here that the clinical benefit, it is the left panel with the threshold across diseases of 100 mutation was string independent of mutation load. You can see here too, look at the middle panel about the prediction model for neoepitopes, that more or less the same kind of difference can be found counting the neoantigen, the neoepitopes, and we might discuss it a little bit more later in this discussion. Question, all these data are whole exome sequencing. A question to all of you. Do you imagine that tomorrow you will perform whole exome sequencing to all your patients to be able to prescribe immunotherapy? The answer is very fast, and it's no, because it's not feasible for cost and time issues. So we need to find a proxy for tumor mutation burden. So let's look at this very nice paper performed by the group of Foundation. 100,000 human cancer had been sequenced there. So first of all, what is interesting in this paper I invite you to look at is that they requalified every tumor type by mutational load. And you can find here some diseases, rare diseases, which were not described previously using whole exome sequencing. So this is a classification of disease by tumor mutation burden by Foundation panel of 315 genes, right? And here they had some of these tumors which also were tested by whole exome sequencing, and you can see that for this tumor having double tests, you could see the correlation between Foundation and whole exome. So a proxy. So let's look with some other platforms, the IMPACT platform from South Kensington, and you can see that the correlation between whole exome sequencing and targeted IMPACT, which is 400 plus genes, is perfectly reliable in that setting with a good correlation factor. Nice publication also by Compozzato and colleagues. They used their in-house panel, the Foundation and the whole exome, again finding a very good correlation between the three techniques. And you can see here what is interesting is this rock curve is showing a shoulder. So there must be, for every disease, a point beyond which mutational burden counts positively and specifically as a biomarker. And this might be, depending on the disease, of course, visible on the rock curve if well performed. Let's go back to my CheckMate 26 trial, making a negative trial, a positive trial in lung cancer. In this trial, everything was done by whole exome, like I told you before, but the people from BMS decided to do in vitro a simulation of reading the same genes, reading the whole exome sequencing on the genes of the panel. It's called an in silico analysis, and you can see the very great correlation. But it's a kind of an easy task because you have already get rid, for example, of the genomic variants that you might see if you only use the panel, okay? But the correlation was very good. But they had some sample too in this trial where they really could perform the two tests without calculation and comparing, allowing them to try to settle down a complex calculation. I can tell you it's not very easy, but a complex calculation allowing you to go from whole exome sequencing to the exact value you would find in Foundation, allowing them nowadays to do a report like the CheckMate 2227 we will see later on. Can you do it with your platform? Because in Europe, it's very stringent. We don't have Foundation One. And we have every center has its own platform, being Illumina, being Ion Torrent, but we all have our platform. So what are you going to do in the future with that? This table describes to you the panels, the large panels we usually have on our platforms, which can vary between 170 genes and almost 600 genes, which makes very different the reading you have of the mutational load, of course, and makes you imagine that by, again, a complex calculation is not so easy. You might potentially in the future be able to use your own platform validated in order to be able to evaluate your mutational burden. I have quoted what OncoMine is publishing on their advertisement, telling that the OncoMine tumor mutation load assay may replace the need for WES. So it's already something that is starting. Every platform tries to tell the fact that they can replace the whole exome. We're very happy about it, but it requires homogenization. And more importantly than that, the problem is you cannot reduce this probabilistic approach to a very small number of genes. There will be a point where by reducing the coverage of the sequencing you do, of the DNA you explore, you will not be correlated anymore. And there is this very nice, I would say, exploration of the minimal set of genes you might use in order to try to replace or proxy the whole exome sequencing. And you can see here that you lose the Pearson correlation test. It's going down by reducing the number of genes, and probably something like between 0.5 megabase or 1 megabase, and probably more than 150 genes are necessary to be able to predict. That's why I told you before, if you have an NGS, it's going to be your large panel. It's not going to be the usual 56 or 60 genes panel. Okay. The other thing is, once you will have your good platform, every disease will have to need a stringent definition of the threshold for your platform. And you can see here a very nice foundation paper again. This is mainly in lung cancer. And you can see that with a threshold of 15 mutations per foundation one, you have predictive ability. But if you lose 12, it's lost in terms of statistics, telling you that this is going to be even more complex for moving the field. But this is feasible, and that's my message. Based on that, do we have data doing that? And again, we only speak about retrospective analysis. So this is data, Vanderbilt and Massachusetts General Hospital using foundation in 236 and 315 melanoma. And you can see that it works very well. You can see the thresholds which are used here, which are 23 of very high mutation burden, but a p-value of high significance. So we discussed it. This is IMvigor 210, phase 2 trial, pre-treated urothelial cancer. And you can see here that, again, by using a Foundation One platform, a very good ability was found to predict the clinical benefit. And this is the next step, the phase 3 randomized trial, Atezolizumab versus chemotherapy, where here again, by using tumor mutation burden as measured in Foundation One, you can observe an overall survival benefit in tumor mutation burden high. And interestingly, look at the right panel. The negative impact that it might have on chemotherapy is really not shown here. So I think this is a biomarker which will help you guiding immunotherapy, but is not something which might dictate the fate of chemotherapy. And the non-small cell lung cancer, stone cancer experience, the RISV paper, it's nice because now you don't define numbers, it's defined by percentiles. And you can see here that, again, by using the impact platform, a little higher coverage than the foundation, you find a very good ability in non-small cell lung cancer. All to say that we have the rationale, but we have already seen that it works to use targeted panels of gene. Still lung cancer, Kovanets and colleagues have shown that across almost all the non-small cell lung cancer trial of Atezolizumab, this is the phase 2 Birch and Fur, this is Atezolizumab in the phase 2 randomized Poplar versus docetaxel, and we have the same data I will show you later about Oak. Foundation One works very well in discriminating, and here you have, keep in mind, it's 16 mutations per megabase which were used in this trial. And that leads me to this. This trial will be presented on Monday. And it was rationally designed as PD-L1 selected, but changed before the database was locked to a primary endpoint of a PFS in high tumor mutation burden. And this is a press release. If you have more than 10 mutations per megabase by Foundation One, you will have a benefit in this trial. So this reality is tomorrow, because as soon as you have your drug, you should be able to manage the evaluation of tumor mutational burden.
Data from the CheckMate 227 trial reported at AACR 2018 showed that in TMB high metastatic non-small cell lung cancer, first-line Nivolumab plus Ipilimumab prolonged progression-free survival compared with chemotherapy. It also provided further evidence that TMB is an important and independent predictive immuno-oncology biomarker in non-small cell lung cancer. Results presented at ASCO 2018 yielded further insights on the different combination approaches and biomarker alignments, including TMB.
This has been shown before. This exercise, still using Foundation One platform, can be done to classify diseases according to their mutational burden and correlate it to the response rate to usual monotherapy, anti-PD-1, anti-PD-L1. And you can see that the correlation is very good, really assessing for you the best way with this technology. In daily practice, can you do it? Potentially in the blood. So I think in 10 years from now, we might be there. I'm not sure we are there. So it was an abstract at ASCO already in 2017, which was trying to compare two techniques that I think in the US use quite a lot, the Guardant for liquid and the Foundation One for tissue. To make a long story short, Guardant and Foundation One in different diseases, non-small breast and other solid tumors. The correlation is poor. You can see the Pearson correlation here, it's really poor. So Foundation and Guardant do not correlate. The reason might be that the coverage, again, the coverage, the magnitude of DNA you cover by your test is 10 times different between both. And in the blood, Guardant is only covering maybe 100,000 base pairs, not as much as 1 million of Foundation One, right? Roche did using their own panel. This is not Foundation Act. This is an in-house panel of more than 400 genes looked at in the blood. It's not daily practice. It's really difficult to reproduce. But by doing that, they can find in the blood, 16 mutation per megabase with their in-house panel was a very good predictor of progression-free survival and also overall survival, with a kind of a proportional evolution, as you can see, of the hazard ratio, which makes it interesting, showing you that it might also be a kind of a continuum in which, however, we will have to define thresholds. Why is it difficult to assess tumor mutational burden in the blood, despite the fact that you have to have a panel large enough? First thing, left scheme here, not all the diseases are equal in the way they shed DNA in the circulation. And the shedding can be very different from one tumor type to the other one and might not be sufficient for tumor mutational burden in the blood in terms of allele frequency. The stage of the disease will define the shedding of the DNA. And the location, the localization, and the tumor burden per se will probably also impact, very importantly, how much DNA you have to evaluate. So my take-home point about practically using tumor mutational burden are the following. Mutational burden is a relevant determinant of immunotherapy benefit, absolutely across cancer types today, and very possibly completely irrespective of PD-L1 expression. Targeted NGS seems to be a reasonable proxy for differentiating high tumor mutation burden versus others. Targeted panels, however, are not designed or optimized to estimate tumor mutation burden. Remember, we have them for drivers, oncogenes, right? Genes covered by the various panels are more likely to be mutated by definition than the other one, so the threshold might be a little different from the one you observe with whole exome sequencing. A minimal coverage of exomes is necessary. We discussed it in liquid and in solid biopsy, and data across testing platforms, your platform, Foundation, the impact of stone catching must be harmonized. We need to move also beyond these crucial metrics. We discuss numbers because it's probabilistic, to potentially more nuanced understanding of what do this mutation mean, as it was discussed before in terms, for example, of neoantigens. Let's just stop 2 minutes on neoantigens. So we have seen before that if you have a good predictive model for your neoantigens, you might imagine to extract a better probabilistic ability than your mutational burden. But in most of the series we have today, these two, I would say, metrics do correlate, match quite well. And you can see here that at least in 2 or 3 of the recent papers, the number of neoantigens and mutation burdens were quite correlated, as well as on the right panel. You can see the benefit of both selection was more or less the same in terms of immunotherapy. So how can you potentially use or exploit neoantigen in the future? So the left patient is somebody who you give checkpoint only. You can also imagine to make the best use of neoantigen by identifying them from the tumor, creating vaccines, and what we were not doing in the past, try to create an immune response by the combination with the vaccine and checkpoint. But you can also, and that's the next step I'll not discuss today, try to expand neoantigen specific T cells. We are already doing it in some centers in Europe and some centers in the US, in order to re-inject the good cells which are stimulated and recognizing the right antigen in the patient. I will just discuss vaccine a little bit with you. Remember that the MHC class 1 and 2 do not present exactly the same type of peptide, so it's very important to predict what peptide will bind to which MHC. And the most important sentence here is, unfortunately, when you do these predictive models, most somatic mutations detected by sequencing do not result in effective neoantigens. You will not find T cells recognizing them. So what can you do? Here you have 500 mutations, and you make your predictive ability, including the binding to the class 1 MHC, and the ability to detect here 80 potential neoantigens. You can test these neoantigens, these synthetic long peptides, or even under the format of mRNA by inducing a presentation by antigen-presenting cells, and afterwards co-culture with T cells to have a functional assay and to see if they work or if they don't work. Once you have done that, you might be able, by a positive stimulation of your immune system and your T cells, to understand what are the good neoantigens for vaccine. So It looks simple. Is it true? I'm not sure it's already what we know how to do, but we have two very interesting papers back to back, and I will just give you the results of these two papers recently published. It was vaccines based on neoantigen, as I described. These are small cohort size, and the two studies provide intriguing evidence for clinical activity of vaccines. So computational algorithms were used to predict the ability of neoantigens to bind, like we said before. In the paper of Ott and colleagues, they vaccinated 6 patients with up to 20 total peptides after surgery. It was melanoma patients, both studies. Only 2 participants had disease recurrence with both, but both achieved a complete response after a re-challenge with anti-PD-1, meaning that here you really show the activity of this vaccine. Sahin creating a synthetic RNA vaccine, each encoding 527 neoantigens. 5 of the 13 participants had tumor relapse, with 1 regression after PD-1 blockade. But, so this is clinically, you could have told me this patient might have done the same thing without the vaccine, but immune monitoring analysis of PBMC in both studies revealed that both types of vaccine, peptide or RNA, are able to enhance pre-existing but weak neoantigen-specific T cells and generate de novo neoantigen-specific T cell responding, showing you that you are really moving and paving the way of some things that we wouldn't have to meet, but we have to, an individually tailored drug on demand, meaning a personalized vaccine for each single patient. Are there other ways to vaccine? Yes, of course. We spoke about the first 2 lines, RNA on synthetic long peptide vaccine. You can also use dendritic cell vaccine. It's being done in many clinical trials, including ovarian cancer, DNA vaccines. So many ways to move and to try to combine with checkpoint inhibitors. We also have this, I can say, a bit old-fashioned using attenuated bacterial vectors or ex vivo dendritic cells. When you will see in the slides, when you will read them, the advantages and disadvantages of the techniques. There are ongoing trials you see in many different diseases, pancreatic, melanoma, breast cancer, glioblastoma, so a bit of unexpected diversity of tumor types using synthetic peptides for most of them, but also RNA vaccines, and we are looking forward to see how this vaccine works. You see almost all combined again with checkpoint inhibitors in the future, and maybe being complementary to other techniques or only a single treatment in the adjuvant or consolidation setting, for example. It's not comprehensive, but on this slide I give you 3 names of very active, I would say, initiatives in promoting neoantigen vaccine, which is a difficult process in terms of clinical trial and experience, but you can see that all have a program in order to make it accessible to our patients tomorrow. And with this, I thank you for your attention.
That's great. Thanks, Solange. One of the questions which has come up a lot is, whether mutational burden and immune infiltration and PD-L1 extraction is correlated or not. Does anyone, Solange, you want to comment on the relationship?
Yeah. I think we have quite strong evidence today to say that PD-L1 and mutational burden have not been shown to be correlated. If you have a sample size which allows you to make the evaluation correctly, you will not find a correlation. About T-cell infiltration, it's a little bit less obvious. I would say today that there's a bit controversy about it, but it depends on the disease. Some disease we have absolutely no data because we don't have good data about T-cell infiltration, like lung cancer, for example. In melanoma, the correlation that they found between TILs and mutational burden was existing but was weak. So I would say it's not so clear. The picture has to be further defined. But we are not using TILs or tumor-infiltrating lymphocytes as a biomarker. So I think the question is a little bit less priority in terms of trying to implement it. What is interesting, mutational burden and PD-L1 is in CheckMate 26, what we could show is it's not a synergistic, but an additive effect. So there might be today or tomorrow an algorithm where having both positive might select the best of the best patients for this type of therapy.
Yeah, I think it's going to vary by tumor type. I mean, small cell lung cancer is a good example where it's 80% plus or PD-L1 zero expression, yet they have a comparable proportion of high TMB as non-small cell lung cancer. There's a lot of technical questions. I don't think we can get into all of them. One question I would have for Nadim, though, is that people kind of comment on whole exome sequencing as a gold standard, but different pipelines will give you very different numbers from even whole exome sequencing. Do you want to comment on that?
Yes, so that is very true that different pipelines will give you different numbers, and so ultimately, you have to lock down your analytic pipeline and what you're actually sequencing. So obviously, Foundation is using the same analytic pipeline. The Impact panel has a lockdown analytic pipeline, but you have to lock both down. And
there's an additional question here in terms of how sample preservation can affect TMB in terms of the quality of the material. Is there a relationship there? It seems to me that a lot of the SOPs have standardized that, though.
Yeah, I think for the most part, purity is sort of the biggest concern in terms of sequencing tumors. So as long as you have a pure tumor and it's been obtained in the last few years, as you had mentioned, it's sort of not an issue with sequencing.
Okay, again, for time reasons, we're going to keep moving forward. Omid's going to come speak to us, coming here from LA.
Thank you. So we've heard some fantastic, phenomenal speeches about tumor mutational burden and the role of PD-L1 and where that goes. I do agree that it's extremely important for us now to take all of that data and, just like Dr. Peters mentioned, evaluate how those help us to stratify and evaluate the results of combinatorial trials that are upcoming. So our goals are to improve response and to find the right people for the right therapy. You've seen something like this where we're not getting everyone in, even the PD-L1 negatives, not a great response. And now we've amassed an army of people who are all here working to understand how to move forward. And this is what we have now, a bunch of combination therapies and multiple trials. And since it starts with melanoma and ends with melanoma, if you came back and updated this would look like a mole with all the trials that are here. We'll all blacken out. So the idea is taking these predictive markers and prognostic markers and evaluating appropriately where to go and which trial is best for our patients, and the ability to do that in a rapid fashion for our patients. So we've heard a lot about these biomarkers, whether it be neoantigen load, looking at the microbiome, et cetera, and how do we go from there? We need to have a model for future decision making, whether it's inflamed or non-inflamed. And I just took this from Dan Chen's paper in Immunity to understand where to go. And of course, the first one is what Dr. Rizvi and others have been talking about. If you have strong PD-L1 and a high mutational load, guess what? You're going to respond inflamed or non-inflamed, and that's what we see from there. But where do we move on? It's the ability to look at the tumor microenvironment to understand where we're failing with the tumor and the immune system interaction and move forward. So I'll talk to you a little about this. I usually talk a lot about melanoma, but this is all generalizable to multiple solid tumor types. And I'll stray from a lot of the melanoma data and talk about what else is going on. Anti-CSF1 receptor inhibitors plus PD-1 are in trial for advanced solid tumors. This is data that was presented at SITC. Tumor-associated macrophages in pancreas and other cancers do create an immune-suppressed environment, and an antibody that can help deplete these can work. And then preclinical data that shows the combination can synergize to enhance anti-tumor activity. So I show you this data here just to understand the role. Granted, not a lot of patients, granted, you see response, but a significant proportion don't. But look at who we're looking at here. These are patients with pancreatic cancer with a confirmed response rate and duration of response and control that is going out 10 plus months. To identify this type of subset of patients with pancreatic cancer and move forward, that's like the holy grail in pancreatic cancer and for other therapies. I'll spend a little bit of time. This used to take up a lot of my talk, but where do we go in places where the immune microenvironment is suppressive, and where does IDO fit in? I think What we've learned now is that we need to go back and look at the data from the randomized trials that were just presented that were negative and find a role for IDO or not. Some of these targets may not be the appropriate target for untreated patients, but may work in relapsed and refractory patients. Remember, not everyone responds, and not everyone does as well as melanoma patients. So what happens when you have a response and then you relapse, or when you're refractory to begin with, even to anti-PD-1, PD-L1, CAR-T, which is gaining more role, vaccine and PD-1, where do we go? And that might be where we take some of these drugs that we've put aside. And given that, I put in an ipilimumab slide just to show you that these were patients that were treated with ipilimumab and an IDO inhibitor. Where do we go when PD-1, PD-L1 therapies are not the right option, to understand where we can bring in anti-CTLA-4 and other therapies in combination? As we move on, when there's no identifiable immune targets, we have to find a way to bring those T cells in. And BRAF mutations have a huge role in melanoma, but they're in 8% of all solid tumors. They're in a small subset of lung cancer, etc. And initial data have shown that MAP kinase inhibitor-induced changes can increase antigen expression in tumors. They can decrease immunosuppressive cytokine production, increase CD8 T cells, and many groups, including at MD Anderson and others, have shown that within a couple of weeks of starting, T cells flow into the tumor, and that may help us. If PD-L1 increases, that may help us get better response. We're all familiar with the data of MEK inhibition and anti-PD-1 in these KRAS mutant patients, where they've seen response rates where there have been no options and benefit. And that's moving on a randomized 3 that's coming forward. And in other tumors, as you can see, as I put up clear cell sarcoma patient that's been treated with combination. This is proof of principle in melanoma. This is Atezolizumab and cobimetinib and vemurafenib BRAF MEK inhibition. This is early data that's been presented, and this is now a randomized phase 3 trial, as there's multiple randomized phase 3 trials going on. But you can see here in 100% of the patients there was some early clinical benefit. Whether that relates to the holy grail of overall survival benefit, we will only see in randomized phase 3 settings. But again, important for us to know the correct biomarkers and create the right trials moving forward in order to understand those subset of patients that benefit. It will not help to overlook things like PD-L1 staining, tumor mutational burden, and the tumor microenvironment, and then go do a post analysis. So these have to be predefined in our randomized phase 3 trials. Anti-angiogenics and anti-stromal agents will bring those patients who have T cells in the periphery or others, bring it in. TVEC, Telimagene Leheprevec, we've heard a lot about data that's been presented in JCO and recently in Cell by Tony Rivas and others, have shown that TVEC itself has the ability to stimulate a antigen response and an immune response. So as Dr. Peters had shown, in her previous talk, the ability to increase neoantigen exposure can increase response. And those of you not familiar, TVEC is injected into subcutaneous or nodal areas. In melanoma, it's shown an increased response rate. It's been approved for locally advanced. In combinations, and this is a combination with ipilimumab in melanoma, it showed a higher response rates and durable benefit. And this is the early data in pembrolizumab. Again, with this combination, there is initial injection of the TVEC into lesions, and we've seen increases in CD8 T cells in the tumor and circulating even before the anti-CTLA-4 and the anti-PD-1, PD-L1 is introduced. And this is a major randomized phase 3 trial that has fully accrued, and we look forward to seeing this information. Now, it's great, it's in melanoma, but Where this drug is being advanced is intraviscerally, so into lesions, intrahepatic injection. And as you know, there are multiple tumors that can have intradermal injection, whether it's triple-negative breast, whether it's head and neck cancer, et cetera. So we believe that this is relatable to other solid tumors moving forward. What is STING? Lead singer of the Police, but also the stimulator of interferon genes. And this is a way to reinitiate interferon signaling and increase the immune infiltrate into tumors. And STING works in multiple different areas. Again, this is a direct injectable that can bring cells into the tumor microenvironment and works in multiple other ways. And again, these trials are now moving in phase 1 to look at multiple solid tumors with direct injection into visceral lesions. What about the setting where you need increased tumor antigen expression? And Dr. Rios talked a little bit about MHC and its role. What if we don't have the ability for tumor and T cell to interact through a MHC, either it's a weak bond or the bond is not durable? And we can talk about that and the ability to increase tumor infiltrating lymphocytes through adoptive T cell therapy. This is bringing TIL therapy to the masses, and this clinical trial where the tumor itself is harvested locally and sent centrally with the TILs made. The patient is admitted to your ICU and infused. And early in melanoma, these are patients who have all seen checkpoint inhibitor. We've seen an initial overall response rate of 29% and tumor reduction in 77% of patients. You can see the stepping stone to a combination with PD-1, PD-L1, and others. Now, this is something that's already being taken forward in lung cancer and cervical cancer also. So generalizable to a multiple subsets of tumor types. Bispecific antibodies, and this is what I call like the Yenta molecule. It's a matchmaker that brings the cancer cell and the T cell together and increases the ability of them to interact through MHC. This is something that's in melanoma, but moving into other solid tumors. And this is a bispecific that needs HLA-A201 to recognize GP100. So one side targets GP100, the other side targets CD3, and then creates this perfectly optimized immune synapse that allows that interaction to create tumor cell death. You can take what you have classically seen as a cold tumor and turn it into a hot tumor. It has single-agent efficacy in cold tumors. A phase 1 trial was very interesting in that it not only showed responses or benefit in patients that had seen prior PD-1, PD-L1 in melanoma, but there were 2 patients who had response, one who had a CR in ocular melanoma. And this moved forward in both tumor types. Preclinically here you can see that even by day 3 you have an increase in the number of PD-L1 positive cells within the tumor. And adding a PD-L1 increases that potency. This is a patient, as I was saying, with ocular melanoma, where there's initially an increase in tumor, but as you can see by week 39, some early response, some stability, but when you see a patient with ocular melanoma like this progressing, they should not make it to week 39. So this drug has been granted an orphan designation for ocular melanoma and is now being looked at in a randomized setting in untreated and then in also pretreated melanoma going forward. It was, as Shustari and others presented, has about a 15% response rate and a 40% clinical benefit. And this is now moving forward in a phase 1, phase 2 trial looking at multiple combinations of this drug in patients with melanoma who have failed prior PD-1 targeted therapy, and also no prior immunotherapy. So as we move forward, no talk is complete without talking about the other checkpoints. I think everyone has seen these, the activating checkpoints, which is like putting your foot on the accelerator on the T cell, and the inhibiting checkpoints. You want to cut the brake and increase the acceleration on these tumors. And whether it's early or late, we're now having a greater idea about where they fit in and how biomarkers can fit. Whether it's tumor mutational burden or PD-L1, some of these other biomarkers are more fluid and can help at other times. And this is data that was presented by our friend in Napoli, Paulo Isierto, looking at Relatlimab. This is a monoclonal antibody that targets LAG-3 in patients who had previously seen PD-1, PD-L1 targeted agents. If you look at the bottom, you can see that's the PD-L1 staining. If you look at the top, the first to the left is looking at patients who had LAG-3 expression greater than 1%, and they had a 45% clinical benefit. If it's less than 1%, they had a 24% clinical benefit. And you can see those patients who had the best, 2 of them had the best benefit who had a CR. Those were PD-L1 negative patients. So an idea of how to move forward in understanding where we're going with these clinical trials. And I'll say it early, I have a slide at the end. My impression and other colleagues is that we're now not looking to do huge trials with hundreds of patients. We're looking to initially cautiously move forward and look at these combinations either early or in patients that are PD-1 relapsers or refractory and find that exquisite responder. I would say that out of all of these patients, those 2 exquisite responders are really important. We need to get their tissue, their blood, their hair, their skin, etc., their primary tissue, and send them for evaluation. And this is the reason, this is the cautious tale. If you want to see great benefit, then there should be trials looking at this combination in those patients that most clearly mimic the exquisite responders. And that's where I think we're going in these clinical trials, to understand why we had the subset that responded so well and to be able to bring a multifactorial predictive model into the next trial moving forward. And then you don't need huge trials. You need smaller trials, show a significant response rate in a place where we don't have an option, whether it's relapse or refractory or hyperprogressor or what, and then go for evaluation. And this slide just says that the majority of them had seen other immunotherapies also. Timing of blockade is important. This is early data presented by the group at Providence, looking at whether it's important to give in combination or with a lead-in. And what they found was in mice models, if you led with OX40, then you could have a greater tumor kill if you then introduce PD-1 therapy. Some of the data has been presented with the OX40 with Atezolizumab. You can see this melanoma patient 1 after pembrolizumab, a very low PD-L1 staining, and then introducing OX40 increases that staining. And also, again, the melanoma patient below. So whether you could increase PD-L1 and then bring in PD-L1 targeted agents and get a better benefit. And you can see this here. This is a patient who was clear cell renal cell carcinoma, initially treated pre-dose with the OX40 compound, and then treated with Atezolizumab with an early response. Not to be forgotten is the ability to possibly decrease toxicity and increase the dosage of a drug that you can give. And so this is maybe the answer to what's the right dose of IPI-1 or 3, or what's the right dose of combination. If you have a probody, which is an antibody that has a linker that is only then cleaved at the tumor microenvironment where a specific protease exists, then you may be able to get the right drug to the right place without all of the other toxicities that you can see. And this is a probody of ipilimumab that's in clinical trials at this point, probody of PD-L1 that's in multiple combinations with data expected at ASCO. And I hope through the talk that we're having together, you can see that the goal here is to get these patients to these trials to understand the benefits and to go forward. Many have heard about the Nectar-214 drug. This is, again, a probody of a CD122 agonist that stimulates the interleukin-2 receptor and preferentially expands CD8 T cells and NK cells and does not affect those T regulatory cells seen here in red. And this was seen preclinically and in a monotherapy trial, but in combination with Nivolumab, we've seen in small numbers in melanoma a disease control rate that's near 90%. Not just melanoma, but the data presented in multiple tumor types here, treatment-naive melanoma or renal cell carcinoma, second line, first line, lung cancer also is showing a disease control rate that is enough for us to look at it in a bigger trial setting. And hopefully the idea of not just checkpoint, but others, bringing something that has shown efficacy in a solid tumor before, bringing interleukin-2 back into the discussion. I just want to come back to the auth data to say that this is a clear indication of that proof of principle that Dr. Peters talked about, increasing neoantigens and increasing neoantigen presentation and possibly increasing those T cells that are at the ready that just need a push. And these two patients then became metastatic, both had a complete response. The exquisite responder, again, for understanding who responds and who does well. And then the ability to have an adaptive biomarker trial that looks at patients, brings them onto trial, then at relapse or at failure, then again looks at those biomarkers and sees what's happening in a dynamic setting. So in summary, multiple combinations that are in the clinic, the biomarkers that need to predict the next steps, and a future role of what to do with this huge amount of PD-1 refractory relapse and resistance that's upcoming.
Thank you.
Okay.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerreview.com/ETR. This activity is supported through educational grants from Bristol Myers Squibb, Foundation Medicine Incorporated, Insight Corporation, and Merck & Company Incorporated.